This voiceover will cover acute respiratory failure in the portion of the chapter in your Lewis textbook. Respiratory failure is not a disease, but it's a symptom of an underlying pathology. The condition affects lung function, oxygen delivery, cardiac output, and/or the baseline metabolic state. The lungs are no longer able to meet the body's metabolic needs, and acute respiratory failure can be classified as either hypoxemic or hypercapnic. In acute respiratory failure, the term hypoxemia produces a decrease in PaO2 and a decrease in SaO2. It can also cause hypercapnia, which is an increase in arterial carbon dioxide, or CO2. In acute respiratory failure, one of the hallmark diagnostic tests is arterial blood gases, or ABGs, and they're going to be used to assess changes in the patient's pH, oxygen level with PaO2 or SaO2, CO2 levels with the PaCO2, and our base concentration, which is bicarbonate. The definition and classification of respiratory failure incorporates multiple concepts. PaO2 is at a level that indicates inadequate oxygen saturation of hemoglobin. This level exists despite administration of supplemental O2 at a percentage of at least 60%, which is about 3 times that of room air, 21%. The definition also incorporates PaCO2, which is going to be higher than normal in respiratory failure. This level is evidence that the body has an inability to compensate for this increase in acidosis or acidemia. And the pH level, if it further decreases, is going to lead to a severe acid-base imbalance. Many patients with respiratory failure are going to have both hypoxemia and hypercapnia. For example, a lot of patients with advanced COPD can have both. So the 4 main broad causes of respiratory failure are going to be a mismatch between ventilation and perfusion, shunting, which can be an anatomical or an intrapulmonary shunt, problems with diffusion at the alveoli level, and then also issues with hypoventilation. And we're going to talk about those in more detail. In the normal lung, the volume of blood perfusing the lungs each minute is about 4 to 5 liters and is approximately equal to the amount of gas that reaches the alveoli each minute. In a perfectly matched system, each portion of the lung would receive 1 milliliter of air for each 1 milliliter of blood flow. This match of ventilation and perfusion would result in a VQ ratio of 1 to 1, which is expressed as VQ equals 1. When this match is not 1 to 1, a VQ mismatch occurs. Oxygen therapy is an appropriate first step to reverse hypoxemia caused by this mismatch, because not all gas exchange units are affected. So a lot of causes of a VQ mismatch include COPD, pneumonia, asthma, and pain. At the lung apex, the VQ ratio is 3 to 3, and at the midpoint it's 1 to 0, and at the base it's 0.63. The difference causes the PaO2 to be higher at the apex of the lung and lower at the base. Values for PaCO2 are the opposite, so lower at the apex and higher at the base. Blood that exits the lung is a mixture of these values. Shunting occurs when blood exits the heart without having participated in gas exchange. A shunt can be viewed as an extreme VQ mismatch. An anatomic shunt occurs when the blood passes through an anatomic channel in the heart For example, a ventral or atrial septal defect, and it bypasses the lungs. An intrapulmonary shunt occurs when blood flows through the pulmonary capillaries without participating in gas exchange. This is going to be seen in conditions in which the alveoli fill with fluid, such as ARDS and pneumonia, or even cardiogenic pulmonary edema. This picture just represents the difference between an anatomical or an intrapulmonary shunt. So the picture on the left is going to be your anatomical, and the picture on the right is going to be the intrapulmonary. So diffusion limitation occurs when gas exchange occurs across the alveoli capillary interface that's compromised by a process that thickens, damages, or destroys the alveolar membrane and affects blood flow through the pulmonary capillaries. Diffusion limitation is going to be worsened by disease states affecting the pulmonary vasculature bed, such as severe COPD or recurrent pulmonary emboli. Some disease states cause the alveoli capillary interface to become thicker or fibrotic, which can slow gas transport. These are going to include pulmonary fibrosis, interstitial lung disease, ARDS, and pulmonary emboli. This is just another picture that represents issues with diffusion limitation. Alveolar hypoventilation is a generalized decrease in ventilation that results in an increase in PaCO2 with a consequential decrease in PaO2. Although alveolar hypoventilation is primarily a mechanism of hypercapnic respiratory failure, it is mentioned here because it also encompasses hypoxemia. So a lot of the causes of alveolar hypoventilation are restrictive lung disease, central nervous system disease, anybody who has a chest wall dysfunction, somebody who has hyposcoliosis, or neuromuscular diseases such as myasthenia gravis, Guillain-Barré. Patients with acute respiratory failure, secondary pneumonia, may have a combination of VQ mismatch and shunting. In this case, inflammation, edema, and hypersecretion of exudate within the bronchioles and gas exchange units are going to obstruct the airways, causing a VQ mismatch, and are going to fill the alveoli with exudate consolidation, which is going to cause an intrapulmonary shunt. Additional contributing factors to hypoxemic respiratory failure include increases in O2 demand, such as with severe anxiety, pain, or agitation. There's going to be a combination of two or more physiologic mechanisms: VQ mismatch, shunting, diffusion limitation, and alveolar hypoventilation. Ventilatory support or supply is the maximum ventilation that the patient can sustain without developing respiratory muscle fatigue. Ventilatory demand is the amount of ventilation needed to keep the PaCO2 within normal limits. Normally, ventilatory supply far exceeds the demand. Therefore, people with normal lung function can engage in strenuous exercise, which greatly increases CO2 production from cellular respiration without an increase in PaCO2. Hypercapnia occurs when the demand exceeds the supply, and the CO2 cannot be sustained within normal limits. The underlying pathophysiology of these conditions results in airflow obstruction and air trapping. Respiratory muscle fatigue and ventilatory failure occur due to the additional work needed to inspire adequate tidal volumes against increased airway resistance and air trapped within the alveoli. These conditions might include asthma, COPD, and cystic fibrosis. A variety of problems may suppress the drive to breathe. A common example is an overdose of an opioid or other respiratory depressant drug. In a dose-related manner, CNS depressants such as opioids, benzos decrease CO2 reactivity in the brainstem. So this is going to allow the arterial CO2 levels to rise. Also, a brainstem infarction or severe head injury may also interfere with normal function of the respiratory center in the medulla. Patients with these conditions are at increased risk for respiratory failure because the brainstem does not alter the respiratory rate in response to changes in PaCO2. Apart from direct brainstem dysfunction, metabolic or structural brain injury resulting in depression of consciousness may interfere with the patient's ability to manage secretions or adequately protect his or her airway. Several conditions prevent normal movement of the chest wall and limit lung expansion. In patients with flail chest, fractures prevent the rib cage from expanding normally because of pain, mechanical restriction, and muscle spasm. In patients with kyphoscoliosis, the change in spinal configuration compresses the lungs and prevents normal expansion of the chest wall. In patients with severe obesity, the weight of the chest and abdominal contents may limit lung expansion. Various types of neuromuscular diseases may result in respiratory muscle weakness or paralysis. Patients with Guillain-Barré, muscular dystrophy, or multiple sclerosis are at a risk for respiratory failure because the respiratory muscles are weakened or paralyzed because of the underlying condition. These disorders may be acquired as a consequence of exposure to toxins, which interfere with the nerve supply to muscles and lung function. Respiratory muscle weakness may also result in muscle wasting during a critical illness, peripheral nerve damage, and or prolonged effects of neuromuscular blocking agents such as paralytics. The inability may occur because of inadequate oxygen delivery to the tissues or because the tissues cannot use the oxygen that's delivered to them. It may also occur as a result of the stress response and the dramatic increase in O2 consumption. Failure of O2 use most commonly occurs in septic shock. In this situation, adequate oxygen may be delivered to the tissues, but impaired O2 extraction or diffusion limitation exists at the cellular level. This results in an abnormally high amount of O2 returning to the venous blood because it is not used at the tissue level. Some of the clinical manifestations of respiratory failure, it might be sudden in onset. An example is the patient with asthma who develops severe bronchospasm and has a marked decrease in airflow, resulting in rapid respiratory muscle fatigue, acidosis, and respiratory failure. It may also be gradual in onset, such as an example is a patient with COPD who develops a progressive increase in PaCO2 over several days following the onset of a respiratory infection. Because the change occurred over several days, there is time for renal compensation, which will minimize the changes in arterial pH. Because clinical manifestations are variable, it's important to watch trends in arterial blood gases and the pulse ox, as well as other assessment findings, to fully evaluate the extent of changes. Frequently, the first indication of respiratory failure is going to be a change in the patient's mental status. Mental status changes often occur early and before any type of invasive blood work. And it's because the brain is so sensitive to changes in O2 and CO2 levels and acid-base imbalances. Examples might include restlessness, confusion, agitation, and sometimes combativeness, which can suggest inadequate O2 delivery to the brain and it should be investigated more fully. At night, the respiratory rate is typically slower, and the lungs of patients at risk for respiratory failure may remove less PaCO2. A severe morning headache may often suggest that hypercapnia occurred during the night. Hypoxemia occurs when the amount of O2 in arterial blood is less than normal. For example, a normal PaO2 in an arterial blood sample is 80 to 100 millimeters of mercury. Hypoxia is going to occur when the PaO2 falls sufficiently to cause signs and symptoms of inadequate oxygen. Hypoxia and metabolic acidosis have adverse effects on the vital organs, especially the heart and CNS. Permanent brain damage may occur if the hypoxemia is severe and it's prolonged. The GI system alterations include tissue ischemia, increased permeability of the intestinal wall, and possible migration of bacteria from the GI tract into the circulation. The patient may increase the respiratory rate in an effort to blow off an accumulation of CO2. This breathing pattern requires a substantial amount of work and predisposes the patient to respiratory muscle fatigue. Another assessment parameter is the number of pillows that the patient may require to breathe comfortably when attempting to lie flat. This is termed orthopnea and is documented as 1, 2, 3, or 4 pillows. The ability of the patient to speak is another indication of the severity of dyspnea. Some patients are going to tripod. The tripod position is sitting with the arms propped on the over-the-bed table, which is going to help decrease the work of breathing, as propping the arms is going to increase the AP diameter of the chest, and it's going to change the pressure within the thorax, making it easier to breathe. The patient may also speak in sentences or phrases or words. They may not be able to speak in complete sentences. You also may see patients with pursed lip breathing, and this is going to increase the SaO2 because it's going to slow the respirations, allowing more time for exhalation, and it's going to prevent the small bronchiole from collapsing, which is all going to help increase with gas exchange. You may also observe retractions, which is going to be the inward movement of the intercostal spaces or the supraclavicular area. And we also might see some movement with the sternocleidomastoid during inspiration or expiration. So some of the diagnostic studies you might see with respiratory failure. A chest x-ray is going to help to identify possible causes of the respiratory failure. Is it massive widespread atelectasis? Is it pneumonia? Another primary test with respiratory failure is going to be ABGs. And as we said, they're going to determine the levels of PaCO2, PaO2, base bicarbonate, and it's going to look at the overall pH balance of the system. It's going to be used to evaluate not only oxygenation, but ventilation. We might also look at blood and sputum cultures, which are going to be obtained as necessary to determine the source of the infection, if that's the case. And in severe respiratory failure, if we're not sure if it's related to cardiac reasons, we might consider doing a central venous pressure or a PA invasive monitoring device. And that's just going to be able to measure hemodynamic parameters more frequently. And the data is going to help to determine the adequacy of tissue perfusion and the patient's response to treatment measures. So some of the biggest nursing diagnoses is going to be impaired gas exchange related to alveoli, hypoventilation, shunting, mismatch, and diffusion impairment. You're also going to see ineffective airway clearance related to excessive secretions, decreased level of consciousness, the presence of an artificial airway, ineffective breathing pattern related to neuromuscular impairment of respirations, anxiety, decreased level of consciousness, muscle fatigue. And so some of the things that we're going to plan in our goals are going to be to keep our ABGs within normal. We don't want to have any adventitious breath sounds. We're going to want to minimize dyspnea. We're going to want our patients to maintain an independent airway and be able to clear their airway secretions. So some of the collaborative management for acute respiratory failure. We want the nurses to be able to teach a patient that's at risk for respiratory failure about deep breathing and coughing, the use of the incentive spirometer, and frequent early ambulation in order to prevent respiratory failure. We also want thinking about the prevention of atelectasis, pneumonia, and complications, as well as optimizing their hydration and nutrition, which can also potentially decrease the risk of respiratory failure in acutely or critically ill patients. So the primary goal of oxygen therapy is to correct hypoxemia. If hypoxemia is secondary to a VQ mismatch, supplemental O2 is going to be administered somewhere between 1 to 3 liters by a nasal cannula. If we need higher levels, we might consider putting them on a simple face mask or a Venturi mask. Hypoxemia secondary to a shunt is usually not responsive to high O2 concentrations, and in this case, the patient will usually require mechanical ventilation. The patient with acute respiratory failure must be able to tolerate the types of O2 delivery systems that we choose. For example, a face mask may cause anxiety if patients are claustrophobic, and this can cause dyspnea, and it can increase O2 consumption and CO2 production. And sometimes if patients are significantly anxious, they might remove their O2 device. So chronic hypercapnia is going to blunt the responses of chemoreceptors in the medulla to elevated CO2. So in situations like this, we know that hypoxia is going to stimulate our respirations. So provide O2 to patients with chronic hypercapnia through a low flow device, which means our patients who are CO2 retainers, some of our COPD patients, we want to limit the amount of oxygen supplemental that we give to them to keep them at that minimal baseline for their PaO2. So 1 to 2 liters per nasal cannula, or a Venturi mask between 24 to 28%. So we don't want to start out putting them on high concentrations of a flow system. We don't want to be putting them on a nasal cannula of 6 to 8 liters per minute. So some other things to consider. Retained pulmonary secretions may cause or can exacerbate acute respiratory failure by blocking the movement of O2 into the alveoli and capillary membranes. And it's also going to subsequently block the removal of CO2 during exhalation. So some things to consider with respiratory therapy is going to be to mobilize secretions through turning, coughing, maintaining adequate hydration through oral or IV fluids, humidification through oxygen or through the ventilator, chest physiotherapy through vibrations, through cupping, airway suctioning as needed, and then also repositioning and working with our patients to effectively cough, such as through huffing or staged coughing. So adequate fluid intake, at least 2 to 3 liters a day, is going to keep secretions thin, and it's going to be easier for our patients who are at risk for respiratory failure to remove them. We also need to make sure that we thoroughly assess their cardiac and renal status to make sure that they can tolerate that amount of fluids per day, as to avoid heart failure, a flare-up of pulmonary edema. So an appropriate humidification device is going to be an adjunct in secretion management. Aerosols of sterile normal saline can be administered by nebulizer, and they can also help to liquefy secretions. Some other things are mucolytic agents, such as mucomist, and we can mix those with bronchodilators to help thin secretions. Chest physical therapy is indicated in patients who produce more than 30 milliliters of sputum per day or have evidence of severe atelectasis or pulmonary infiltrates. As needed, we can also airway suction in patients who are unable to effectively expectorate secretions. We can do this through NP, OP, or NT suctioning. So non-invasive positive pressure ventilation with BiPAP is most useful in managing chronic respiratory failure in patients with chest wall and neuromuscular disease. It's not appropriate for patients who have excessive secretions, a decreased level of consciousness, facial trauma, or hemodynamic instability. So some other things for management or therapy, we might consider bronchodilators such as albuterol, Ventolin, to reverse bronchospasms. We also might consider corticosteroids such as solumedrol to be used in conjunction with the bronchodilators to help with spasms and also to reduce inflammation. If the patient's hypervolemic, we might consider diuretics to reduce some of the pulmonary congestion that might be associated if it's heart failure. If it's atrial fibrillation and it's increasing a respiratory rate or heart rate, we might consider using broncho beta blockers, calcium channel blockers to decrease the heart rate. And then if it's infection related, we're going to consider antibiotics, but we're not going to use them preventatively or proactively. And then if it's a combination, somebody's ventilated, they're on the vent, and they're asynchronous with the vent, and it's causing problems with their oxygenation, we're going to make sure that they're adequately sedated and they have pain medication to help them relax. So goals and related interventions to maximize oxygen delivery are going to be essential to improve the patient's oxygenation and ventilation status. Interventions are going to be directed towards reversing the disease process that resulted in the development of respiratory failure in the first place. Was it hyperventilation? Was it a VQ mismatch, shunting, or diffusion limitation? Cardiac output reflects the blood flow reaching the tissues. BP and mean arterial pressures are important indicators of the adequacy of carbon dioxide or adequacy of cardiac output. So the dietitian is also going to be important as they're going to collaborate along with the healthcare team to determine the optimal methods of feeding patients, to determine their optimal caloric and fluid requirements. Additional issues affecting the nutritional state include the hypermetabolic state and critical illness. As a hypermetabolic state is going to increase the caloric requirements needed to maintain the body weight and muscle mass and allow these patients to heal and to recover. So our expected outcomes if somebody has respiratory failure from whatever is to maintain a patent airway with effective removal of secretions, have a normal baseline respiratory status with rhythm, rate, breath sounds, to maintain adequate oxygenation as indicated by normal baseline arterial blood gas levels, and to experience normal hemodynamic levels, normal BP, normal heart rate,